Asking what is, well, I'll give a brief definition of what is mental health, and then I want to take us actually more importantly into the issue of attachment theory and how attachment styles can be one and seen as one of the major ways that we can understand mental health issues in children and adolescents. And then I want to look a little bit at emotional regulation and resistance to emotional regulation in terms of the particular attachment style that a young person or child might have, and how resilience can be a buffer to the risk of mental health. And then finally look at the considerations of the arts movement psychotherapy research and what we might assess in terms of referral for treatment. That's a lot, but I'll try and get through quickly. So these are just some of the types of therapies. You probably know all about these. They take place in the NHS. We also have school counsellors in secondary schools, and there's a move now to take them into primary schools as well. But not all children will have access to all of these therapies. The ones that children and adolescents will mostly have will be systems family therapy. Can you hear me okay? Systems family therapy and some play therapy as well that takes place in the NHS. And of course, the all-pervasive cognitive behaviour therapy. So most of the main psychological therapies are the talking therapies, so we talk. But we also do have arts therapies which are recognised and accredited by the Health Professional Councils, the Health Care Professional Council, which is a national governmental body that recognises the arts psychotherapies, except for, unfortunately, Dance Movement Psychotherapy, because we were too late to get our application rubber stamped at Parliament. They ran out of time, so we have to go down a different route, which is the UKCP, which was the organisation you mentioned earlier. So we're an organisational member of the United Kingdom Council for Psychotherapy. We are psychotherapists. We call ourselves psychotherapists, not therapists. We have to go through quite a rigorous procedure to become members of this association. It's a voluntary body. It's not a government body, but the government do recognise its professional. I can't remember what it's called now. Professional systems. I don't know. It's a register anyway. They recognise the register for the UKCP. We tend to use the term counselling more as it's less stigmatising than the term psychotherapy, especially for young people. And some therapies that I mentioned earlier will be recognised by our National Institute for Clinical and Health Excellence, which is a guideline for the NHS for the treatment of mental health conditions. This is for adults. There aren't any national guidelines for the treatment for children apart from depression, which is CBT. So what about the arts therapies? Well, yes, we have the arts therapies. We all have professional associations separately, not like your very good idea of bringing them all together. But the research evidence is very, very poor indeed. Some schools do have arts therapists. It's on a sessional basis or a part-time, one-day-a-week type basis, where they might do individual work and group work in art therapy, drama therapy, dance movement therapy, and music therapy. Not just special schools, mainstream schools as well, but obviously more in special schools. We have the Children and Adolescent Mental Health Service, which we have in every single town. We also have child development centres for developmental disorders, but the CAMS service do take arts therapists quite seriously, and they nearly all have an arts therapist of some kind, or a play therapist. Play therapy is getting bigger and bigger, and we've got now a training in one of our universities for masters in play therapy. They've got their own professional association, but no research evidence, unfortunately. And we also have inpatient for young people, eating disorders particularly, units for inpatient, where the arts therapies are quite prevalent there too, especially we have dance movement therapy in there because of body image, because we make the link with body image. So just a quick look at the survey. The survey was done this May, so it's really up to date, by the UKCP, which I've just mentioned, but also by the British Association for Counselling and Psychotherapy, another big organisation for counsellors and psychotherapists, and the Association for Counselling and Psychotherapy. And they surveyed 3,000 NHS therapists, and that was one of the one of the items that they reported, that children need increasingly seem to see more severe levels of illness, and they need to get help. And just the past 5 years has really the availability of services has plummeted, but the demand has increased. They also report 76% reported number of posts inadequate to meet the client's needs, and waiting times have increased enormously. It's at least 6 to 10 months for a CAMS referral, for a young person to be seen even for assessment in the child and adolescent mental health services. So it's quite a long time for waiting. Obviously inadequate. So we do have future plans to help with this. So I looked up what are we going to do about this? Lots of plans. Well, a green paper was recently developed jointly, so they're talking to each other, the health and education, which is really good, about preventative measures in schools and so on. We've got Mental Health First Aid, which is a new initiative, government funded. Every single secondary school will have a training, or staff will have a training in raising awareness of mental health issues, and they will be able to then have conversations with the young people and then signpost them to where they can go to get support. The Department of Education is conducting a national survey asking schools what they think should be involved and what sort of treatment and what sort of priorities are needed to take next steps. We also have the Joint Care Quality Commission and Ofsted conducting another review separately from that. Think Ahead are training social workers, specialised social workers, ones that are trained in mental health. And we have the CAM service as well. So we've had another, I think, £400 million invested in CBT in the CAMs. So CBT for children and adolescents. We wouldn't like quite a bit of that money. It could be good to go to Arts Therapies, but we haven't got the ear of the government, unfortunately. And then Public Health England are pushing for more preventative work in schools. For example, schools counsellors, not all schools, they have their own budget, they can spend it on what they like, and they don't all see emotional well-being as being a priority. So they spend it on, I don't know, play equipment in the school playground instead. But they are pushing. Public Health England are pushing for that because they see the rise that we have in the in mental health. I've got to have 3 hands here. So very quickly. So what is mental health? This is just one definition. I'll just let you read that. You probably all know what it is anyway. And we know that resilience is positively associated with high life satisfaction, but we can develop resilience, so we can nurture and promote resilience from a very young age. Resilience and self-regulation, emotional self-regulation, have been shown to be linked, and also self-regulation and attachment also are linked. So just quickly some statistics. 50% of mental health issues are established by the age of 14 in the UK, and 75% by the age of 24. I'm trying to keep up with myself. Yeah, we're pretty low down the league table. 10% of children between 5 and 16 have a clinical diagnosable mental health problem. And this makes 13%, so I don't know quite where the statistics went here, but those are the sorts of problems that have been identified. Obviously, conduct problems are underlying a lot. And 20% of adolescents may experience a mental health problem in any given year. That's the WHO in 2003, but also there are the Children's Society in 2008, and 70%. And then I found, because I'm also involved in mental health raising awareness for students at universities, and I've done a bit of research on that, and 92% of students said that they experienced some form of mental distress, which is an enormous number, actually. Between 12 and 20% reported having a mental health problem. So I'm at the moment tasked with evaluating a training programme with university staff, raising their awareness of what are the signs for mental health or at risk of emotional need, so that they can have the conversation and then signpost the young person. These are young people 18 to 24, something like that, for some support. We do have GPs on site in the university, and we have a big counselling service as well. We're trying to develop mindfulness practices as well in the student union, so young people can learn about that. So this is for children. The statistics there from 2004. These have gone higher since these aren't the most recent statistics. I'll just let you read those. So 1 in 15, I'll just point out, between 16 and 25-year-olds, that's 1 in 15 have attempted self-harm of some kind. I think somebody's already mentioned conduct disorder is often underlying the mental ill health. And this is another statistic just found this week. We're 47th out of 49 for poor well-being in our young people. But we know that mental health issues increase as they move through adolescence. And the latest figures for depression in the 18s, under 18s, between April 15 and June 16, was a 12% rise. So that's a big rise. We also know that girls are more the prevalence of girls who are identified and diagnosed as depressed is rising. Now, I was really depressed when I started reading these figures about the UK, but I actually think maybe it's not so bad, because we're a very open society and we've been pushing to reduce the stigma for mental health, because it's very much stigmatised. People don't want to go through the psychological therapist's door. They don't want to be seen to go to psychological services. So we've been trying to reduce that stigma by disclosing. Politicians are disclosing. Teachers are disclosing. Lots of people are disclosing that they've got or have had a mental health issue. And I think this is encouraging young people to disclose as well. So I don't think it's necessarily that we're actually, more, stressed or whatever, or have fewer resilience in our society. I think people are disclosing. Prince William, Prince Harry, yeah, they're leading the way, exactly. Yeah, I forgot about him, thank you. So recent research with the PISA, this was really depressing when I read this. This was 2015. We're the least happy country, with 38 out of 48 countries in the OECD countries. Only 28% of students are happy with life. Boys are happier than girls. Don't know why that is. Pupils, our schools, we're very target driven. They're hugely anxious about getting the best targets, getting their tests. We test from the age of 7. Crazy. 73% are anxious even when they're well prepared for tests. So that was really depressing. And the bullying also has gone up. 25% report they've been victims or are victims of at least one act of bullying. And this is just in schools, I don't think. I think it's also happening in universities. I think it happens in any organisation, actually, bullying, compared to the OECD average of 19%. So these are the sorts of diagnoses. I'm sure there are others. You know all those. MUS is medically unexplained symptoms, which is my particular area of research. Well, what can affect mental health of young people? Well, we know sexual abuse, exploitation, assault, and so on, but also other parental factors, debt, financial debt. We've had 7 years of austerity in the UK. The poor are getting poorer. Everybody's in debt to some extent, including the government. Huge amount of debt. That can affect. Also, animosity around divorce, residential care for the children after divorce, animosity about that. All sorts of parental factors can come in, as well as early attachment issues, which come in. And I used to work with looked after children in residential settings, and they nearly all had attachment issues because they've been often neglected or sexually abused or whatever. So what we're looking at is trauma. We're looking at the interaction of biological, cognitive, psychological, and social factors. This is a secure attachment. So we have 4 aspects of attachment. We have the safe haven, we have the secure base, the maintenance of proximity, being close to the significant other or others, and we have the distress when the significant others, when there's a separation. So how can this contribute to our understanding of mental ill health? So in healthy attachment, we find, for example, and this attachment was developed by John Bowlby initially in England, in London, and there's been since researched by Ainsworth and other people over the years. And they don't talk to each other, the psychoanalytic community and the attachment. They have this, problem with each other for some reason. It's to do with attachment. Yes. Anyway, in healthy attachment, the child will use the caregivers as a secure base. So they'll feel safe, they'll feel happy, they'll be able to explore because they feel safe, they can always come back to that safe base. They're comforted by strangers, but they show preference for the main caregiver, and obviously when the caregiver departs, they cry, they get upset. But then they can continue to explore when their caregiver returns. However, it has been shown that love alone is insufficient for a secure attachment. So if the environment is anyway negative, or is felt as unsafe for that infant, that they still won't make a good attachment. So love isn't everything. As somebody said, the child will still run up to the parent and give them a big hug. I mean, the child still loves the parent, how much they're abused by them. So it's associated with higher reappraisal and higher levels of resilience, and it's partly mediating on life satisfaction, feeling well-being. And every individual's psychological well-being will differ from each other's as a function of their particular attachment style. So there are lots of this. Well, I'm going to bring in the attachment styles. And I say attachment style is one of the underlying factors. So an insecure attachment is seen to be an underlying factor to mental ill health. So what are they? Avoidant dismissing. I've got some more details on this. So the avoidant dismissing, if you think about in adult attachments, that you might be kind of distant from your partner, sort of rejecting in intimate situations, or even in supervisory relationships. You keep your partner at arm's length. The partner wants more closeness, that sort of thing. Intimacy is equated with a loss of independence. So fairly self-sufficient, preferring to be autonomous than interdependent. Cool, uncontrolled, very stoic, self-sufficient. Good in a crisis, though, because they're not very emotional. Takes charge and quite detached. And the child will avoid to make attachments with the avoidant dismissing. So ambivalent or preoccupied. In an adult, this would become a fairly insecure person in intimate relationships, constantly worried about the rejection or possible abandonment, preoccupied with the relationship and how it's going. Needy, really, and requires ongoing reassurance, perhaps merges with the partner, perhaps scares the partner away because they're so clingy. Ruminates about unresolved past issues, overly sensitive to the partner's actions, takes everything personally. Poor personal boundaries, communication rather than being interpersonal, is not very collaborative, just speaks in dictatorial ways, unaware of the responsibility they might need to hold in the relationship, blaming others. And then the disorganised or unresolved. An adult might be an unresolved mindset, unresolved emotions, frightened by memories of prior trauma. And issues from the past will not have been mourned or integrated, resolved properly. They're usually antisocial and seem to show a lack of empathy. They may also maltreat their own children. So really, what we're saying is attachment patterns are intergenerational. The styles are reflected in the construction of this internal working model, which eventually becomes our intrapsychic structure upon which our future relationships will be shaped. So it's like a foundation for our future relationships. That doesn't mean to say it can't change, because of course there's neuroplasticity there. Yeah. Okay, so the patterns are generational. So they move down through the generations, but it's not what happened to the child that matters most. It's how the child is then supported to deal with that. So it's how we as a community, as a society, offer the support for the child. So the links between attachment and trauma are quite a lot. There's links made between childhood sexual abuse or survivors, as we could call them rather than victims, and the preoccupied attachment. There's a link between all types of trauma and different types of attachment. But what we can say is not all insecure attachment is necessarily Not all types of attachment develop insecure attachment, or not all traumatized children develop insecure attachments. So what happens is a stress response then is triggered in the child, and then because of the maltreatment, and that compromises the attachment. So the key biological parts that you should come into play becomes dysregulated. So there's a lack of attunement between, like, the caregiver and the infant, and that means that the attachment can never really be consolidated. People who suffer trauma have higher rates of serious illness. We know that from the general population studies. Higher rates of chronic diseases like heart disease, cancer, diabetes, and so on. But they also have women particularly have a 9-fold increase in the prevalence of heart disease, which I think is quite interesting, as women are more emotionally and often more available for therapy and so on, and are more emotionally expressive. So I would have thought it was the other way around, actually, because men don't tend to disclose feelings so easily. But we know that 60% of women with gastrointestinal illness also have an abuse history of some kind. And I know from my own experience with MUS patients that chronic pain, chronic fatigue, and fibromyalgia, there is often, not always, but often, a trauma associated with that has not necessarily been processed or is even known about by the patient. But it's been, if you like, taken on by the body. So there's just a few insecure attachment behaviours that I would say to teachers to have a look at, see if they can notice any of that. So other behaviours would be disobedience, chronic disobedience, tantrums, argumentative, always needing to be right, no smiling really, quite withdrawn, defiant, tearful, and sometimes avoiding eye contact. And people have observed these early warning signs, and they've actually, there's been research on the different patterns of behaviours that we can look for, and all of these things I would give to the teachers to think about when they're going into their placements, either nursery, primary, or secondary school. Think about these and just notice, because these could be early signs of trauma and attachment difficulties. And these are the behaviours that the children and young people report. So it's different from observed. These are the things that, so feeling numb, like nothing matters. These unexplained pains and so on, feeling helpless, hopeless. That they're smoking a lot, drinking a lot and so on. They can't remember things. They're confused. They're often angry, upset. So we know, therefore, that attachment style starts with the process of regulation between the mother or the caregiver and the baby, with this very, very constant attunement or lack of attunement, where the caregiver, the primary caregiver, will play with the baby through sound and movement, through mirroring the baby, through echoing the baby, through interacting in movement with the baby. So Daniel Stern calls it the dance between the baby and the mother. So we know that this process of regulation by the mother helping the baby to regulate their own emotions, then the baby can learn how to regulate themselves. Stressful events are highly emotional. We know that because stress happens. You know, we all have stressful events in our lives. But self-regulation can help us deal with those stresses. And we can actually cultivate this self-regulation. It moderates deviant behaviour and it correlates with resilience in adolescents between 17 and 19 years. And we know that secure attachment is associated with the capacity to reappraise a situation. So to reappraise a situation and maybe walk away, or reappraise it in some way so that we can reframe it, so we don't see it quite the same way. So we can have choices in how we see things, how we understand things, how we feel things. We also know that emotional regulation and the outcome of resilience may be connected through attentional control, and in terms of making a conscious effort not to pay attention to something or someone or an event, to actually not think about it, to not give it any power, and also to reappraise situations. And finally, the most significant adversity for demonstrating resilience, whether that's a trait, whether the resilience is already there, or an outcome of a treatment, can be via a chronic stressor. So actually, we only know whether somebody's developed their resilience by the next stressful event, and they can cope. They do better day to day with that particular event, how they deal with that event. So why bother even supporting, promoting the socio-emotional well-being of children and adolescents? Well, there's been lots of research on... We had a Prime Minister, David Cameron, who wanted to do a happiness survey because he wanted to find out how happy everybody was in the UK. It never got off the ground, but he wanted to see whether people could contribute in these various ways, because he knew that if people feel well and people are coping, we get higher overall productivity because people go to work, people aren't absent, better educational outcomes, lower crime rates, much stronger economies, lower healthcare costs, because we know these different difficulties cost a lot of money, improved quality of life for the people, and we live longer with less health problems and an improved family life. So overall, it's worth having because we get a healthier society. So just take us back to dance movement psychotherapy for a minute. This is one definition, there's probably quite a few out there. It's an expressive psychotherapy, and it's a relational process. The client and the therapist engage in an empathic, creative exploration using more body movement and creative dance to assist in this integration of the emotions, physical, the cognitive, and the social and spiritual aspects of the self. So we have got some research, not a lot, but we've got some, and this was just a very quick global summary of some of the research. It's not a Cochrane review by any means, it's not systematic. But there's a few papers from 2000, actually that's me, 1979, the first paper I wrote with emotionally behaviourally disturbed children and moderate learning disability, looking at social adjustment. There were conduct disorders, and I was able to show some emotional impulse control. Followed by some other papers where people are working with different children, teenagers, with children with developmental delays, looking at linking dance, creative dance and feelings of social well-being, preschool children, mothers' participation, linking elementary children at risk of PTSD, and mother-infant dyads. So we have had some with children, not a lot, but something, and with young people quite a lot more, 2 slides. So I started with me with young offenders in 1995, where I was looking at, again, at impulse control and improved behaviour outcomes. And then we go to some in 2006, somebody there working with 2 adolescent girls with medically unexplained chronic pain, which I was interested in. And 12 weeks of DMP improves emotional responses and modulates the neurohormone with mild depression in teenagers. A couple of case studies. And then we got a randomised trial there. Again, with psychosomatic and stress-related symptoms. That's the same one. Okay. So I just want to move on now to what is it that a movement intervention can offer in this insecure attachment child or young person. Because we're able to promote change in terms of using non-verbal behaviour and verbal, we don't not talk, we do talk, but we are particularly skilled in promoting attunement through rhythm, for example, through the breath, through mirroring and echoing, and through this interactive synchrony, sometimes with music and sometimes not. And this intersubjective relationship that we have with the child or the young person can promote this sense of attunement and maybe can correct this dysregulation where the original attachment was not so good. for whatever reason, because the mother also had an insecure attachment, maybe, probably. So we can offer something different, and we can become another attachment figure, however old or whatever age. We can become another significant other for that child or young person. And I think that's important because it gives them an opportunity to if you like, integrate that experience. So just to leave you with some more questions, really. Can DMP offer a safe haven for the emotional exploration or the enactment of early unconscious developmental issues for integration and change? Can we establish any criteria for assessing the child or adolescent being referred to DMP? And what about identifying the information that the therapist needs from the referrer? So what do we need to know in order to offer a treatment program that's suitable for that particular child or young person? And planning the program with DMP needs to address that information. So we need to look at the information, look at the referral information, and then plan the program around that. Any questions?
I got several ideas now to study. Yes. Thank you. So we will go for 15 minutes.